Good afternoon, sir.
So can you read the slides and let me know the abnormality? So what is your interpretation on this?
Sir, I have an elderly gentleman with a history of smoking and hypertension, uh, having a very severe excruciating chest pain for the last 6 hours. So I'm suspecting cardiac pathology such as acute coronary syndrome or aortic dissection, as he is pale, sweaty, tachycardic, and also is hypotensive. And there is excruciating pain in his right leg, so probably he's having ischemia of his right lower limb, and he is aliguric, and his labs are showing a picture of AKI. uh, there's anemia, leukocytosis, thrombocytopenia, elevated liver enzymes, probably ischemic hepatitis, and creatinine is also elevated, so maybe he's having AKI. I don't know the baseline. And blood gas is also, and the electrolytes are showing hypernatremia and mild hyperkalemia. Blood gas is, I don't have chloride to calculate anion gap. However, it's going with mixed respiratory and metabolic acidosis with high lactate.
Okay, so what do you think is the possible pathology here? What is your
Sir,
differential diagnosis?
my differentials are acute coronary syndrome and acute aortic dissection with multi-organ involvement in the form of DIC, AKI, ischemic hepatitis.
Okay, great. So this is the X-ray of this patient, and okay,
I don't see the X-ray, sir.
yeah,
Also, my differential would be acute pulmonary embolisms also, sir.
yeah, yes.
I can see the X-ray. It's an anterior posterior view of X-ray with a very widened mediastinum. Okay, widened mediastinum with a
Yeah.
apparent cardiomegaly, and the lung fields looks clear. There is mild blunting of the left costophrenic angle. ECG is consistent with ST elevations in inferior leads 2-3 AVF with reciprocal ST depressions in V1 and V2. And also there are ST elevations in V4, V5, and V6. So it's consistent with inferolateral.
Okay. So what does that mean? So what is your interpretation?
My interpretation is most likely there is aortic dissection involving the coronary arteries of right coronary and lateral LAD.
So you have already told me about the differential diagnosis and the interpretation of the laboratory and the blood gas findings. So how will you confirm the diagnosis?
Sir, I would like to do a basic test initially to begin with, including troponin I cardiac enzymes, and I would do a bedside focus, transthoracic ultrasound, and lung ultrasound, and also would like to do a CT PA and high resolution CT scan and CT angiogram to rule out aortic dissection. Sir, I cannot listen to you, sir.
Yeah. So any other investigation that you would like to do apart from CT and aortogram? Any other thing?
Sir, I would like to do here kidneys are also involved, so I would like to do an renal ultrasound, abdominal ultrasound to look for any extended dissection, and I would
So if you have to do a 2D echocardiography, so what questions you will have in your mind while you do a 2D echo and you want to
Sir,
chase your differential diagnosis?
sir, 2D echocardiogram, I would like to rule out very urgent causes such as pericardial tamponade, cardiac, and I would like to rule out severe LV dysfunction, LV failure, regional wall motion abnormalities, or biventricular failures. Okay. So any acute valvular pathology such as mitral regurgitation or aortic regurgitation.
Okay. So any other pathology that you would like to see in the CT scan?
I would like to see dissection of the ascending and ascending aorta to classify into Sanford A and B. Second, I would like to look for any thrombus in main pulmonary artery or right and left pulmonary arteries. I would like to see right ventricular strain, RV strain. Uh, I would also like to, yeah, these are the things which I would like to see in the heart for the heart. At the same time, I would like to see the parenchyma also, lung parenchyma also.
And how does your classification will help you to prognosticate your patient?
My classification of Sanford or DBK or other classifications are there. Sanford A and B are most commonly followed, and Sanford A is a dissection of ascending aorta. So I would immediately involve the cardiothoracic surgeon because the treatment of choice would be to go for surgery. However, I would transfer the patient to intensive care, manage his blood pressure acutely, and start him on beta blockers such as esmolol in certain arterial lines. And whereas type B, descending aorta, uh, I would like to conservative management, and I will consider thoracic endoscopic vascular surgery such as TEVAR, and again control of surgery and looking for signs of organ perfusion and managing them. Yeah.
Okay. So what is your blood pressure target in this patient and heart rate target?
Sir, I would like to target heart rate less than 60 per minute and blood pressure systolic less than 110 and diastolic less than 160 millimeters
How
of
does
mercury.
that help in this situation?
It will prevent further dissection and decreases the afterload of the heart and prevent the further formation of the false lumen, sir.
So this patient was given fluids and analgesics, but we couldn't see any significant improvement in his clinical condition. He became drowsy, hypoxemic, and got intubated and ventilated because his respiratory parameters were worsening. His hourly urine output also shown consistently low values even after large fluid boluses. And he received noradrenaline infusion because he had sustained hypotension in spite of fluid therapy. And cardiovascular thoracic surgeon and his team was asked to review the patient after an echocardiography confirmed acute aortic dissection involving thoracic aorta and need for urgent surgical intervention. A CT thorax was done to know the extent of the dissection, and surgery was planned accordingly. So, in the CT scan, what do you see as an abnormality? And in 2D also, you see something abnormal. Would you like to comment on this?
Yes, sir. I see the plaques view of the echocardiogram here with regurgitation of the LVOT, and there is a false lumen also I could notice because of the mosaic pattern. And with the CT thorax, I see there is a contrast leak in the descending aorta. However, ascending aorta I could not appreciate here. And also, I could see there is a pericardial effusion and there is a contrast noticed in the right and left ventricles.
Okay, and how about the 2D echo?
The 2D echo, I could see LVOT view here, plaques view, and there is aorta is quite dilated, and there is regurgitation I could see because of the mosaic pattern of the blood flow.
Okay. So now, in addition to this vascular pathology, the CT scan would show anything else?
Y- yes, sir. CT scan could show me the other pathologies such as lung involvement uh, in the form of effusion, uh, pneumothorax, or hemothorax, as well as it can show pericardial effusion. eh, Yeah,
Okay. So how do you explain severe multi-organ failure syndrome in this patient?
it is uh, because of ischemia of organs, because of hypoperfusion of the organs at the level of the brain, at the level of the heart as well, coronaries, at the level of the kidneys and abdominal aorta. I would expect ischemia of because of the dissection of the both ascending and descending aorta. There is ischemia happening to the organs at different levels.
Okay. So how will you do your routine investigations? How frequently would you like to do these investigations?
I would definitely involve multidisciplinary team, including cardiac and cardiothoracic teams, including intensive care. I would admit him into intensive care with continuous monitoring, working on airway, breathing, circulation, securing all the lines, including central line, arterial lines, and I would continuously monitor all his vitals and do a blood gas frequently, ABG 1 to 2 hourly, and monitor his GCS, monitor his oxygenation, monitor his urine output through Foley's catheter, examine his abdomen, and do acetyl lactate, do frequent CBC coagulation profile every 4 to 6 hourly, and troponin and cardiac enzymes, serial ECG every 6 to 8 hourly.
Okay, fine, fantastic. So this patient underwent a thoracotomy for aortic root hematoma. And then in addition to that, this patient also had a coronary artery dissection with the blood oozing into the pericardial space. Patient underwent replacement of both ascending and ascending aorta and the aortic valve, followed by oversieving of the proximal right coronary artery at the site of dissection, and bypass grafting with saphenous venous graft was offered. This patient was shifted to the ITU, sedated, paralyzed on ventilator following completion of the surgery, and in next post-operative period in the ITU, this patient's 24-hour was very storming. He was on very high vasopressors and inotrope support. He had short runs of pulseless VT, which was reverted by defibrillator, and his hourly urine output reduced further and was high colored. The right leg was acutely swollen, tense, and black, and the blisters were also identified. And these were the investigation that was done. So, what do you think? What abnormalities do you find here, and how do you consider this patient's management further?
So the picture is consistent with there is swelling and discoloration and blistering in the anterior aspects of the leg with marked swelling. So I'm suspecting compartment syndrome related to possible hematoma versus accumulation of the fluids there. And I would also like to rule out DVT and ischemia also at the same time. So the labs are consistent with leukocytosis, high creatinine going with AKI, hypocalcemia, hyperkalemia, and elevated liver enzymes, AST, high CPK going with rhabdomyolysis. Blood gas is consistent with metabolic acidosis, mixed respiratory and metabolic acidosis, with very high lactic acid. So my diagnosis would be compartment syndrome with rhabdomyolysis, sir.
Why this patient has suddenly developed this compartment syndrome or rhabdomyolysis, as you said?
So there are different possibilities. One, it could be related to procedure related complications could have happened. Second, patient could have developed heparin induced thrombocytopenia because the platelets here I don't think so it's written here about the platelets. However, it is a possibility that he might have developed thrombosis, and he could have developed ischemia of the lower limbs on the right lower limb.
Suddenly, why he should develop ischemia of the limb?
It could be due to thrombosis, peripheral,
De
maybe
novo
he
thrombosis or thrombus from somewhere
dislodge
else? Yeah.
thrombus dislodgement to the
Where?
peripheral artery.
What could be the source?
Could be the cardiac source, cardiac.
Or anything else? Cardiac? But the heart did not show any thrombus or any vegetation.
Yeah. Uh, should say it's-
Okay, so any other differential diagnosis apart from your rhabdomyolysis and compartment syndrome?
I
And
would
what
like to,
clinical and laboratory parameters you would like to assess?
sir, I assessed the electrolytes. I've seen hypocalcemia, creatinine, blood urea are elevated, liver enzymes have been elevated. There is metabolic acidosis, severe metabolic acidosis, which is uncompensated here. In this case, it's both mixed respiratory and metabolic acidosis uh, with very high lactic acid, and CPK is quite elevated.
So what will be your strategy?
So my strategy would be again multidisciplinary team approach, airway breathing circulation approach, and I would like to consider. Uh, 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 I would like to consider look at the fluid status, and then if he is responsive, I would like to resuscitate with the fluid, looking with the dynamic assessments of the fluid resuscitation. But if I have found any signs of fluid overload, in this case, I would go for renal replacement therapy,
What
and
are
also
the
involve immediately the surgery for fasciotomy to release the pressure of maybe 2 point or 4 point fasciotomy.
okay? Anything else that you would like to do?
I would like to give anti-hyperkalemic measures and correct acidosis, sir.
If this patient has persistent hyperkalemia, persistent rhabdomyolysis, how will you treat?
Sir, I would start him on renal replacement therapies.
So what will be your key prescriptions?
Sir, as this patient, I would like to go for CVV HDF, sir. Go for continuous veno-venous hemodiafiltration. I would like to prescribe CRRT effluent dose of 25 to 30 ml per kg, and I will like to decide based on the hemodynamic instability how much I would like to start and remove ultrafiltrate.
Okay. Anything else you would like to do on CRRT? Your goal?
Uh, I, Sir, in this patient is having hypocalcemia, so I would not prefer to start him on citrate because he might develop citrate toxicity. Uh, and I also investigate for heparin. If there is any contraindications to start heparin, then I would consider alternative ways. Otherwise, I will keep a blood flow pump of around 100 to 150. Then I would keep him on dialysate and pre and post dialysis replacement fluids, and then I will continue CRRT.
Okay. So, as you said, continuous renal replacement therapy you would like to offer. Why not your hemodialysis?
Hemodialysis, if the patient is hemodynamically unstable, he is in a shock state with ischemia of multiple organs, he will not tolerate the intermittent hemodialysis.
So, what will be your settings for dialysate, replacement fluid, and your pre-PBP prescriptions?
Sir, I would like to decide based on my how much is my effluent flow rate. So based on that,
How
I would
much
like to decide.
effluent flow rate you would like to keep? this
I
patient?
would keep between 25 to 30 ml per kg per hour, sir.
Okay.
Then I would decide I will equally divide the dialysate flow rate and replacement flow rate equally. Say, for example, if I start effluent flow rate around 2300, I would like to keep dialysate around 1000 and replacement 1000. And then again, I divide it into pre and post filter and then ultra filtrate, depend on the filtration rate I would like to remove.
Okay. So how would that help you?
So that helps me to keep the access pressures, filter TMPs, and then it will help me in both dialysis and ultrafiltration. So,
Okay. So you would not like to use citrate. So
sir, ideally, I would like to use citrate, but in this patient is already having hypocalcemia. I would like to correct calcium too, but I will keep an eye on calcium. Then, before the patient the blood enters post filter, I would like to see the ionized calcium too at the same time. But here, liver is also involved. I'm worried that this patient may develop citrate toxicity.
okay. Okay. So this patient was uh, investigated further, and then surgical opinion was also sought. And this patient was found to have acute compartment syndrome of the right leg, and urgent surgery was advised. How do you classify compartment syndrome as, on the basis of what? Uh, how do you really act on? Do you call every swelling as compartment syndrome or something else?
So, sir, I would like to have serial monitoring of the size of the length, and then clinical examination I would like to do, and correlate with laboratory data, and also there are ways to measure the facial pressures also, but I'm not very sure how we do it. I never done. So not every swelling is compartment syndrome. So it should have uh, the local pressure and mean arterial pressure, perfusion pressure should be lesser with signs of organ hypoperfusion. We call it as compartment syndromes.
Fine. So this patient underwent bone amputation, and uh, considering his vascular damage, there was extensive debridement which was also offered. But ultimately, a bone amputation was the surgical choice that could be offered to him. And then this patient was shifted to ICU, sedated, ventilated, on noradrenaline support, which was on higher doses compared to the pre-op values. His peak airway pressure started increasing from 30 to 45, and plateau pressures also rose to 35 from 27. And we had to give tidal volume of 8 ml per kg, and respiratory rate was 29, and his arterial PCO2 was 52. PO2 was 64 on FiO2 of 70%. And his PEEP requirement was also 10 centimeters of water. And his mean arterial pressure was 68 millimeters of mercury. And he remained completely anemic. So now this patient is readmitted to ICU. So what are your major challenges here in this patient and new findings that you see?
Sir, this patient is having ongoing organ failure. Now, the challenge is his hypoxemic respiratory failure related to ARDS he developed because of elevated peak pressures and plateau pressures. However, he is being managed with 8 ml per kg. That is, I think we should decrease it to 6 ml per kg of predicted body weight. And his oxygenation is also an issue here. So we need to keep him an optimal PEEP. And this is a challenge. And he's still aliguric, so I would like anuric actually. I would like to continue CRRT and fluid restrictive strategy with possible ultrafiltration to keep him on negative side. And immediately, I would like to do a chest X-ray also to rule out the causes of elevated peak pressures and plateau pressures. However, peak and plateau both have been elevated, so which is going with consistent with the ARDS. However, I would like to rule out hospital-acquired pneumonia, ventilator-associated pneumonias, and all.
Okay, so what rescue therapies you would like to advocate here? And how
Sir,
will you take care of this ARDS patient?
Sir, I would go for a lung protective ventilatory support. I would like to accept permissive hypercapnia, and I would like to decrease the tidal volumes to 6 ml per kg, 4 to 6 ml per kg of predicted body weight. I will keep him on optimal PEEP and decide of PEEP and
How
FI2
will you
ratio.
decide that optimal PEEP?
Sir, there is a table, ARDS net table, where we can do an arterial blood gas at target the PO2 above 55 millimeters of mercury, PCO2, pH more than 7.3, and based on the oxygen index, I would like to titrate the PEEP. And also my target would be to keep plateau pressures less than 30 centimeter of water. However, driving pressures and transpulmonary pressures also have been, but there is no clinical strong evidence to use them.
So these patients' plateau pressures, driving pressures remain consistently high, and he remained extremely hypoxemic as well. So what are your strategies?
Sir, my strategies would be now, as he is having ongoing ischemia compartment syndrome or oliguria, prone ventilation is not that great choice. So I would consider VV ECMO, sir.
Okay, you would not like to give any prone positioning in this patient?
Prone position, there is his recent surgery, aortic surgeries have been done. I'm not sure how it's feasible regarding prone. Otherwise, Prosiva trial definitely there is an opportunity to improve the oxygenation in prone ventilation. But in this particular patient, I'm a bit worried, sir.
You would like to offer him VV ECMO. So what are your settings in VV ECMO initially? So how would you?
Sir, yeah, I would start him on VV ECMO, and then I will keep him on sweep gas flow as well as pump flow around 4 liters and sweep gas around 3 liters per minute. And then I would uh, anti anticoagulate him, and then I would uh, keep ventilatory settings minimal to and keep FiO2 of around 50 to 60 PEEP and decrease the tidal volumes.
And how will you wean this patient from ECMO?
So once the patient reversible causes, etiology has been well controlled. If the patient is on minimal vasopressors and inotropes and his oxygenation is well maintained, then I will slowly go down with sweep gas flow and assess the patient's oxygenation frequently. And then this is how I will wean.
Any role of nitric oxide or prostacyclines or heliox?
Sir, there is no clear benefits, sir. And they have been tried, but there is no clear benefits in.
Would you like to give steroids to your patient? Now he has ARDS.
So there is
What
no
could be the
role of
cause of
steroids.
ARDS?
No role of steroids, sir. Steroids have.
Why this patient has developed ARDS? What could be the
This is idiopathic uh, that and also related to the sepsis, inflammatory cytokines, biotrauma.
okay? You would like to use any filters here?
Cytokine storm filters. Yeah, there are studies about it, but yeah, we can use it through CRRT. Yes.
Okay. Any other diagnostic measures that you would like to do next in this patient?
Uh,
Diagnostic measures.
Diagnostic
You
measures.
would like to do any CT imaging or anything else in this patient?
CT, CT imaging. I'm not sure. So CT.
Okay, this patient's, ARDS was handled with reduction in tidal volume from 8 ml to 6 ml per kg of ideal body weight. And we could reduce the plateau pressures, respiratory rate and PEEP was increased. Patient was completely sedated and paralyzed. And recruitment maneuver was attempted to improve the oxygen status, but it did not help much, and this X-ray was done. How does the recruitment maneuver help in this patient? What is stress and strain index, and what is mechanical power?
The stress index, if it is more than one, it is considered as bad, and you can see it as a scalloping in the peak inspiratory flows. That actually I listened this to your lecture, sir, before, but I forgot. I'm sorry.
Okay.
Yeah,
Okay, so this was the chest X-ray which was
yeah.
done recently. What do you think? What abnormalities do you see here in this X-ray?
So I see endotracheal tube in place below the level of the clavicles. I can see right CVC, left vas cath. I see. I don't appreciate any NG tube. There are bilateral infiltrates. There is apparent cardiomegaly and left lung atelectasis.
Okay, so what would you like to do here?
I would like to keep the patient on optimal PEEP again to improve the atelectasis and continue the lung protective ventilatory supports.
Any other diagnostic modality that you can advocate here? As you said, there is a
I can go
possibility
for
the left side.
bronchoscopy to improve the mucus pluggings.
How often do you want to do bronchoscopies when the patient is on BV ECMO?
I'm not sure.
Any other abnormality that you see in this X-ray?
Mm,
Do you think that this X-ray is appropriate or any abnormalities that you see here?
Regarding the endotracheal tube, I think it's too deep in.
Mhm.
And I
Okay.
could see some, yeah. Mhm.
You could see central line, you could see Ryle's tube, you can see endotracheal tube.
So in this image, yeah, the Ryle's tube is, I could not appreciate it under the below the diaphragm here. Yeah.
Okay. So what will you do? You would like to do a bronchoscopy in this patient. So what precautions you would like to advocate while doing bronchoscopy in this patient?
Uh, Oxygenation, the endotracheal tube should be at least 7 to 7.5 to pass the bronchoscope, and all aseptic precautions must be maintained by both the operator, and we must make sure that the peak pressures are not high, and immediately post bronchoscopy I would like to do chest x-ray to rule out any pneumothorax, and I would like to keep the patient well sedated and paralyzed to avoid coughing, to avoid barotrauma and volute trauma, and take samples and send it for the pathology.
So what do you expect in your ball? And
So,
your
well, I would like to expect any gram positive and gram negative and fungal cultures. I will do AFB cultures. I will send. If I'm suspecting immunocompromised patient, I would like to send even PCP pneumonia tests.
okay. So how will you treat MDR organisms? Suppose this patient has grown Klebsiella, MDR. So how will you select your antibiotics?
Sir, I would like to initially start empirical antibiotic based on the local antibiogram policy of the hospital, and then I would like to involve the infectious disease team, and I would like to closely follow the culture and sensitivity report, And then, based on that, I would like to start him on a broad spectrum antibiotic, gram-negative coverage here in this patient. If the patient is sensitive to carbapenems, or I can start him on meropenem. Otherwise, if the patient is resistant to that, then I would consider escalating it to uh, higher classifications such as ceftazidime, avibactam.
You would like to consider
For
a
this,
resistance pattern here? You would like to see any resistance pattern?
uh, this patient is actually is just admitted in a with acute aortic syndrome. I do not expect him to have an MDR bug. So I would like to involve the ID team and local antibiotic policy, and I will also correlate clinically, uh, and FIO2 requirement and all that stuff.
Okay. So this patient had left-sided collection, and then the ICD was placed. 800 ml of blood was drained, and there was marginal improvement in the ventilator parameter after that. And this patient also underwent percutaneous tracheostomy. And then later on, patient's condition improved with respect to the vasopressors and inotropes and ventilator support. He was weaned off from paralysis and sedation. However, the patient remained unresponsive even after a few days. His clinical examination showed GCS of E1, M2, and BT with bilateral symmetrical pupils reacting to light. And bilateral plantar reflexes were non-elicitable. So what sort of abnormality do you expect here?
So I would like to rule out acute brain insult in this patient because of the low GCS. However, pupils are reactive. I would like to do a CT brain to rule out acute brain insult. And if the patient, at the same time, acute brain insult in the form of ischemia or any bleeding, and as there is bilateral blunt reflexes are absent, so I would like to rule out critical illness, myopathy, sensory motor neuropathies.
Mhm.
Uh, yeah, and I would like to rule out even seizures, ongoing seizures such as non-convulsive status epilepticus by doing Massimo or continuous EEG monitoring. I would like to review the metabolic panel causing any other causes such as high ammonia related to medications or electrolytic abnormalities such as very low sodium. I would review the metabolic causes. Okay. And yeah, so
And how will you differentiate critical illness neuropathy from other entities?
critical illness neuropathy, basically it's a exclusion of it's a diagnosis of exclusion here. I would like to rule out first of all any major pathologies such as any cervical cord involvement, spinal cord pathologies are absent. And then by doing an electromyography and nerve conduction studies, if there are decreased action potentials, then I would come to a conclusion. And all the electrolytes and all it should be within normal limits.
Now, what would you do to further elucidate his neurological condition?
I would involve the neurology team uh, to uh, to get to a conclusion regarding his low GCS. I would continue to stop all sedative and paralysis and assess the GCS of the patient frequently, including brainstem reflexes. However, people's reflexes are present here, and I would uh, do a good involve the occupational therapy and involve the physiotherapy for his critical illness neuropathy. And I would like to improve his nutrition. That's very important. And DVT prophylaxis and correct electrolytes.
How will you prescribe nutrition to this patient?
So I would like to calculate nutritional status by indirect calorimetry based on the VCO2 and VO2 consumption. And then in general, they will require around 25 to 30 kilocalories per kg. However, I would like to start half of it to prevent refeeding. And then I would like to work on protein, nitrogen intake, and glucose and fat intakes and electrolytes.
So this neurologist was consulted, and considering his poor neurological status, the CT brain and EEG was done. EEG did not show any epileptic form electrical activity, and the CT showed these findings. What findings do you interpret here with this CT image?
So this is the non-contrast city brain with the loss of sulci and gyri. So it's consistent with cerebral edema, loss of gray white matter differentiation. So I'm strongly suspecting uh, hypoxic injury to the brain.
So how will you confirm again hypoxic brain injury?
Sir, I would
Is
like
the
to,
CT scan sufficient enough, or you have to have some other prognostic markers or other imaging modalities that you can advocate here?
uh, as he mentioned here, EEG is not showing any malignant pattern such as burst suppression. I would like to do a brain perfusion scan to rule out any empty bulb sign, any absent of cerebral circulation, transcranial Dopplers I can use. I can use somatosensory evoked potentials uh, by stimulating at the median nerves to look for the activity at N20. I would like to do neuron specific anoles, and I would like to do a cerebral angiogram, digital subtraction angiography to look for loss of cerebral circulation cutoff.
Now, how do you explain this severely impaired cerebral status of your patient to the family?
Sir, I would involve their family members, including my team members, my consultant, and other specialities. I would arrange a meeting in a separate setting, and I would use the spike model, and I would invite them and ask them the awareness of what they know about the patient and what's happening. I expect that I would have updated them on daily basis. However, I would like to tell him that he had suffered a severe cardiac insult, leading to impaired blood supply to his organs. We tried our best to help him and prevent morbidity and mortality. And then this is what has happened, and unfortunate things have happened for him. And we would, however, his reflexes are still there. We would like we need to have some more time to see for, and I would definitely break the bad news that the prognosis is poor. Yeah, and I will help them emotionally, and then I can give them my phone number, and again I can have a meeting with them again. Yeah.
Because I am a family member, I'm very devastated and I'm not very happy with the outcome of my brother or patient. And I'm really, really annoyed and very, uh, you know, angry with the team that who has taken care of my patient. And now I have a great financial burden as well. And I'm not in a situation to pay the bills. And I've called a local gun and politicians and then created havoc in the hospital. You, as in charge of the ICU, how would you handle this situation?
So again, I will sit down with the family members, especially his brother, and again involve my team, the both my colleagues as well as the other specialities involved, especially in this case cardiovascular thoracic team and neurosurgery team and neurology team. Sorry. Then uh, I will try to explain to him again that this is not a medical error. It is expected uh, because of his condition. We tried our best. However, if he has queries and he is very upset, I can refer him to the hospital ethical committee to look into the matter. I will also support him that he can raise a complaint and make an investigation. So the hospital committee will work on it. However, I would be realistic and give him a breaking bad news again that uh, we tried our best and this is what has happened to your patient. It depends on the hospital policies how we are dealing with. Despite of this, if he's really upset, angry, then I have to take help of security, sir, to protect my patients as well as my colleagues.
Okay, fantastic. Great. All the best.
Thank you, sir.
We
Thank
will
you.
have a debriefing later on. Probably the dates will be announced to you. And you
Okay.
will also have a
Yes.
Viva exam. And then the debriefing also will happen later on. So good luck
I'm
to you.
listening to your lecture, sir. Actually, I stress index also. I read your lecture. I forgot. Sorry.
No problem. Doesn't matter. Revision is very important. Okay, keep
Thank
it
you,
up.
sir. Thank
Keep
you.
it up. All the best.
Thank you very much. Thank you.
Sure. Thanks. Bye bye. Good night.
Bye. Good.